Thank you for the opportunity to have a chat to you all tonight about my research work, but in the context of headache, because that's what we're here for Headache Week. And so I'm going to be talking a little bit, giving you a little bit of background on headache, but in the context of concussion research, because I am a neurotrauma researcher. I'm interested in what happens following physical injury to the brain. And so I will focus on headache in the context of post-traumatic headache. So, but firstly, to give you a little bit of background on headache, headache can be the big question people ask, oh, I've got a headache or I've got a migraine, which is it? And, it's perhaps important to kind of get a bit of a handle on that, because it depends then how you treat people as to what kind of headache they might have. So a headache can be caused by lots of different causes, and I encourage you to go to the website. Headache Australia's website provides a plethora of information on the different kinds of headache. I had no idea there were so many kinds. And so it's a really interesting resource, and you can see headache can occur as a consequence of allergies or of dehydration, of fever, blood pressure changes, all sorts of things. And these can cause a headache. But a migraine is a neurological disorder. It sort of takes it to the next level. It can be quite distressing and disabling. Usually it's one-sided, one side of the head, and can be pulsating. It's often associated with nausea or vomiting, and can be associated with increased sensitivity to light or sound. So it actually affects 15% of the population at some stage of their life, which is quite a high number. And it affects females more than males, generally speaking, and can be affected by hormonal cycling. The causes aren't fully understood, but there are a range of triggers, and you can get a lot more information on the Headache Australia website, all about different triggers that might lead to migraines, and various types that are increasingly only just starting to be recognised, like vestibular migraine, and some of the different types of symptomology that can come along with a migraine. The migraines can be classified as to either episodic or chronic, depending upon whether you have more or less than 15 per month. Most people don't progress, so just because you have suffer from episodic migraines doesn't mean you'll move on to the chronic, more constant form of the disorder. But the risk factors for progression to a more chronic migraine state can be the overuse of medication and also depression. So the treatments are quite varied. There can be non-pharmacological treatments around educational components, mindfulness, CBT type therapies. Physiotherapy, where you combine physical and psychological treatments, can actually be quite effective, more effective than either one alone, and can reduce the duration of migraines. And then pharmacotherapy can relieve pain due to your standard kind of pain relieving drugs, but also prevention. So lowering one's blood pressure can reduce one's risk of migraine. And there's a number of other therapeutic strategies that are in the pipeline and being tested in various stages of clinical trials. But the most important message of all is to seek medical advice. It's really important to seek qualified advice. Medication has to be controlled. Overuse can worsen and exacerbate the whole problem. And in particular, talking about headache as well as migraine, important to see the doctor if there's abrupt or severe headache, anything associated with stiff neck or numbness, and any of those kind of symptoms that might indicate that you might have a more severe or different kind of medical diagnosis, like stroke or serious infection. Chronic headache that is worse after coughing or sudden movement can also be an indication that you need to seek medical advice or a new headache pain. And particularly of relevance to the context we're talking about today is a headache after a head injury, particularly if that headache worsens. So this brings us to the subject that is the focus of my research, and that is neurotrauma. So that occurs as a consequence of a physical injury to the brain, often in the form of traumatic brain injury. So these are severe injuries in terms of the consequences on the health system. They're very expensive. Total annual cost of $8.6 billion in Australia. And that does not include the costs of the mild injuries like concussion. And these have profound consequences that go beyond the financial. The personal impact on people and their carers can be very profound. It's an interesting fact that up to 80% of people in the criminal justice system have experienced a traumatic brain injury. So there's substantial societal costs of these kinds of injuries. And repeated concussion, such as in sport, can worsen outcomes further and has been linked to later neurodegenerative disease. So we often hear about concussion in the context of sport, but there are multiple causes of concussion. It's actually more common to experience a concussion from a fall or from a motor vehicle accident. But 80 to 90% of the traumatic brain injuries are these concussions. So you might think that, okay, concussion, it's not a particularly severe sort of injury. Most people recover, it's just a bit of someone's had their bell rung. But it's more than that, because 1 in 5 patients who experience concussion go on to have longer lasting symptoms, and that's referred to as PPCS, or persisting post-concussion symptoms. This is when the symptoms last for longer than, say, 1 to 3 months. People are not recovering within the normal time span that you would expect. So the symptoms of both concussion and of the persisting post-concussion symptoms fall into a number of domains. So there's sort of 4 different domains that have been described, including the physical domains, and headache is top of the list for the symptoms that are associated with the physical problems of concussion, but also vomiting and fatigue and sensitivity and nausea. Then there can be cognitive symptoms, which is kind of that feeling of fogginess and slowed down and having difficulty remembering things and perhaps being a bit confused. Sleep disorders, where people are sleeping more than usual or perhaps less and having difficulty falling asleep. And then the psychological domain of symptoms, which can be associated with anxiety or depression. People in my space love to classify things, so I'm going to show you another few classifications. One of these is where the way patients present with their symptoms can be classified into some clinical profiles or trajectories. And so again, fatigue features and vestibular or dizziness type symptoms or problems with the eyes tracking together. But there are 2 of these domains associated with headache. So post-traumatic migraine and also cervical headache, which is associated with neck pain or dysfunction around the neck area, as well as anxiety and mood issues. Again, another beautiful diagram, which a highly regarded paper had in it quite recently. Again, 6 different domains where headache and migraine were grouped together. But you get the idea. Concussion is not a single uniform disease state. It can take a range of different manifestations, of which headache is one. But it is the most common one. Headache is in over 90% of people with concussion. So it's to be taken seriously and is the most frequent symptom. Post-traumatic migraine, so a more severe migraine form of headache, is present in 15 to 33% depending upon the study. Often in association with other symptoms, but it's perhaps worth, there's a sort of few little bullet points I want to run you through that should show that relationship between migraine and headache and concussion. The mechanisms of concussion and a migraine with aura might actually be similar. So the actual brain chemistry changes are thought to be quite similar in those 2 conditions. And if you have post-traumatic migraine, so you've developed migraines just after the injury, that's a risk factor for a more prolonged recovery, so taking longer to recover from that concussion. And it's also related to worse cognitive and balance issues. Patients who have had a family history of migraine are more likely to present with this post-traumatic migraine. So there's all these links, and so it's now recognised that migraine is a concussion modifier. It may increase the risk of sustaining a concussion, and that's a weird one, because how can having migraines make you more likely to hit your head? But there does seem to be a link there. People seem to are more likely to get a concussion if they've got a risk of migraine, but it's not necessarily causal. And there is certainly an increased risk of poor outcome following concussion if you have migraine. So taking a step back now to what actually happens when a patient enters the ED, what's the process or the trajectory of a patient through the healthcare system? Often patients will present to an emergency department and they'll be treated in accordance with a sort of set protocol when they're treated by the emergency department physician. And the big thing that the emergency department physician wants to find out is there a more serious problem than concussion? Is there a skull fracture? Is there a bleed on the brain? And they'll be making a decision as to whether or not to do a CT scan. And so that's really the beginning, middle and end of what the ED physician wants to know. And they will send you home with some follow-up. And in particular, what are the warning signs? So if these things happen 24 hours, within 24 hours after your injury, you should immediately go back to the ED. So things like feeling faint or drowsy or can't be woken up, but a constant severe headache or a headache that gets worse. That's one of the symptoms. If you have that manifestation, immediately back to the emergency department. So repeated vomiting, there's a list here, but headache certainly features. So once one has been discharged and has gone back home, there used to be a bit of an idea that you had to sit in a darkened room for a week or so following a concussion. That's actually been shown now not to be the case. It is not the best way forward. 24 hours of pretty complete rest is probably pretty good. But after that, it's a process of relative rest and graded return to activity with various stages. And this is just one of the quite a number of guidelines that are available online for the various sporting codes and so forth, and this is probably indicative of what most of them say, but there's a symptom-limited activity, so gradually reintroduce normal activities, but the big trick is that as soon as symptoms worsen, you should stop doing what you're doing. So gradually increase activity until the point at which symptoms worsen. That might lead to some light aerobic exercise like walking, a sport-specific exercise like running as time passed and symptoms weren't getting any worse, then non-contact training drills, and then into full contact practice, and then on to actual sport playing if we're talking within the sporting context. So it's clear that actually putting someone straight back on the ground after they've experienced a concussion is not in line with the best practice protocols of how to manage a concussion. So we've got all of these issues come towards, we've got a patient who's worked his or herself through the clinical scenario, they've been to the emergency department or the doctor, but there still remains a clinical problem. Patients aren't necessarily being treated well, they aren't recovering well. And these can perhaps be distilled down into two major issues. Firstly, that clinicians can't predict which patients are going to go on to have poorer outcomes. We don't know which one of the 5 is going to have problems, so you can't then direct that patient to a more organised or intensive care. And in addition to that, there are limited treatment options available. So even if we could identify which patient was going to have poor outcomes, we don't know what to do with them to help them. So for the moderate to severe traumatic brain injuries, that's really centred around a non-specific management of intracranial pressure. Outcomes are often poor for this, and the clinical trials that are trying the different things to try and improve outcomes suffer from the fact that they're often conducted in small numbers of sites and don't have enough patients to be able to actually prove anything meaningful. In the mild traumatic brain injury or concussion space, treatment is not nationally consistent. There are some good clinics dotted around, but there's not a clear sense of what we should do nationally for patients who have suffered a concussion. There's a lack of community awareness, and I'm finding that patients often seem to slip through the net. You hear about patients that are 2 years after their concussion and they're still suffering. So this is all very well, but it's not enough for me just to have an opinion. It's important to reach out to the community and see what the community has to think about this. And we conducted about a year ago a community conversation on concussion, which Brendan actually attended, which is great. And that was facilitated through the WA Consumer and Community Health Research Network. And we had 15 participants, both clinicians and consumers. And we asked a couple of questions. Firstly, what's the biggest gap in the current understanding of concussion? And what does recovery look like? And what should it look like? What's important to research? What should we be spending our research dollars on? And they came up with a number of research priority areas. The facilitators sort of distilled all of the various conversations, and there were a number of outcomes, and I'm going to focus on 2 of those today. And one of them is evidence-based treatments, and then research regarding predictors for poor outcome. And then, so the research that I'd like to talk about as we move through this talk is in this space, looking at research regarding predictors. How can we figure out in advance which patients are going to go on to have poorer outcomes? So why is that important? Why do we want to do that? Well, it is important to be able to predict poor outcome following a concussion. It would reduce redundant imaging. If we knew they were going to be okay, we wouldn't need to put them through the CAT scan or an MRI. It might indicate the need for more intensive monitoring. Maybe this is someone who's showing signs that they might not get well so quickly. It would enable an individualised patient prognosis and enhance all the whole auxiliary care around that patient. Importantly, for someone like me who's a neuroscience researcher, it allows us to identify cohorts for clinical trials. If we don't know who's going to recover, we don't want to treat everyone in a clinical trial. Clinicians are not going to refer people to a clinical trial if they're going to get better anyway. So we need to be able to identify those people at risk and test whatever therapeutic strategies we want to trial on those at-risk patients. And so this leads us to the research I'd just like to do a little showcase of today. This is research from that's been pulled together by my PhD student Ola Gotts, and it was very much a collaborative study with clinicians Daniel Fadovich from Royal Perth Hospital, Carmela Pestel from UWA, Mike Beineveld, Melissa Licari, and we conducted a relatively small scale first pilot study, our first research in this concussion space, where we recruited 62 patients from the Royal Perth Hospital Emergency Department, and with the idea that we realise no one outcome is likely to be predictive. It's more complicated than that. So we collected a lot of different information about the patient themselves and the nature of their injury. We conducted some neuropsych tests, looked at blood biomarkers, and also on a subset of patients did some MRI imaging. And we followed them up 1 month later to see whether they'd actually had, their symptoms had progressed and whether they had developed this persisting post-concussion symptoms. So the final ends in this study, the final number of participants was only 36. So this was a learning experience for us. We've started to realise what you need to do to make sure that patients will actually come back for their follow-up and be able to get all the testing done in a good way. So this was our first foray into this space. The people who came into the study had experienced their concussion from a range of different means, predominantly falls. So, and that matches with the literature, that most people experience their concussion from falls rather than sporting accidents, which were this dark blue piece of the pie here at 8%. So we diagnosed this persisting post-concussion symptoms using some pretty standard questionnaires, or whether people really were suffering on a couple of different measures of their neuropsychological assessments. And on that basis, 5 of our 32 participants developed these persisting symptoms, which again is about right in line with the literature. So this is a complicated table, but I'm just going to pick out a few little bits and pieces out of it. Our statistician, whom we have to take the advice of course, she advised us that given it was a relatively small scale study, we didn't have to reach statistical significance to think it might be useful to study this more in another bigger study. So these are the outcome measures that I'm going to put here on this table. And I draw your attention to whether someone had had a history of previous traumatic brain injury. If they have, they were nearly 5 times more likely to have persisting symptoms after their concussion. Similarly, if someone had had a history of a psychological disorder, perhaps they might have suffered from depression or anxiety in the past, they were over 4 times more likely to have persisting symptoms after their concussion. So this is not a statistically significant finding. We can't sort of take this as a take-home message definite, but it is worth studying further. We also looked at the history of headaches or migraines, but in fact none of our people with persisting symptoms were migraine or headache sufferers. So it was not conclusive at all. Again, too small to say, but it certainly didn't seem to be a particular predictor in our particular study. Then we looked at a range of these neuropsychological tests, and this one called the R-bands was the only one that actually reached what we call statistical significance, where the p-value is less than 0.05. Again, we don't want to take too much from this, from a small scale study, but it did look like some of these neuropsychological tests looked as though they might be reasonable predictors of poor outcome following a concussion. I'd like to just show you the actual raw data because it helps you to understand the nature of the problem with this. So I'll step you through it slowly. Looking at these 3 different measures, the R-bands measures of the neuropsychological tests, and dividing up the people who recovered normally in the blue and the people who had persisting symptoms at the 28 days. Their score on these R-bands, they overlapped. So there was no clear indicator that if someone, say for example, scored 80 on these R-bands, they could be either going to recover normally or have persisting symptoms. The fact that the data overlap shows you that there is no one measure that is predictive of outcome. So it's likely that we're going to have to get a suite of different measures that we can put into some sort of advanced statistical computer modelling in order to be able to identify a number of different factors when taken together might indicate poor outcome after concussion. So one of these measures that we could consider to look at is blood biomarkers. This is a particular very expensive machine which is called a Simoa, and it allows one to measure proteins in the blood at a really, really high level of sensitivity. So it's 1 × 10⁻⁻15 amount of an individual protein that this system can pick up. So we took our blood samples and we sent them off to America, where this machine was the only place we could get the samples analysed. Since we did that study, we now have machines in Australia, which is good news. And what we found, though, that for these particular blood biomarkers that are creating quite a stir in the literature in the concussion space, we found that there was no difference between people who recovered normally and people who had persisting symptoms. So here, the red and the blue are all dotted in together. However, for one of the markers, GFAP, there was a significant increase on a whole population level when we compared it to controls. So it looks like it might be useful for diagnosis, for example, and that's what other studies are starting to say the same thing, but it does not look like it's particularly useful. These particular blood biomarkers are not looking particularly useful for prediction. We then did a small subset of patients, 15 of them, where we did some MRI. And one of the measures that we looked at was the connections between brain regions. And you can do kind of an averaging thing where all the controls and all the traumatic brain injury people are put together, and the difference between the two comes up in red. And so you can see that there were a few differences, but none of those actually reached statistical significance for this study. And then we did some region of interest analysis using a fancy computer program called FSLIs. And that did identify one particular region where if you set a threshold and looked in that particular region for changes in the MRI, you could see that there was a difference again between people who had had an injury and controls, but there's too few patients assessed to see whether that was predictive. But it's looking interesting. The measure was related to one of the tests, the neuropsychological tests that measures one's ability to see different things in space, and that's what that brain region does. So that was nice. So it kind of was a bit of an internal correction for us, or a comforting factor about the whole thing. But what we get from that is that we need to do these analyses on a larger number of patients. And so our take home from this particular pilot study was that no one measure is likely to be predictive of persisting symptoms, but the neuropsychological outcomes do look like they're quite interesting, as do some of the demographic factors, like whether people have suffered an injury in the past or a history of neuropsychological disorders. Some of the anxiety and other tests also look like they might be a little bit interesting. I think that there's a lot to be developed in the MRI space. There are a lot of new measures coming forth which will be really interesting, and so that's a space that we're very keen to get into. But it's clear that a larger scale approach is needed, and that we're going to have to look at quite a lot of different outcome measures. Which brings me to our current clinical trial, which we've just started in the last few weeks, called the CREST, the Concussion Recovery Study. And this is the large scale study where we're going to be able to determine which of these measures might predict poor outcome following concussion. Our first objective with this is actually just to get a handle on the scale of the problem. We're going to generate a registry of 500 people who have suffered concussion and just track where they've come from, get a bit of WA specific data in this space, which is really lacking, and determine the incidence and get maybe some idea of the demographic factors. And then in a smaller subset of these people, we will do a much more comprehensive assessment of their pre-injury factors, their factors around their injury, and how they're treated that might be used to predict their persisting symptoms. So we're looking at neuropsych tests again, the blood biomarkers, probably some different ones this time because I don't think the Samoa ones look particularly interesting for this outcome measure, more advanced MRI measures, exercise tolerance, which is a big one that looks like it might be predictive. People can't raise their heart rate enough if they're suffering from their concussion still, and we're going to follow up for a much more extended period. So that study is underway, and we're actively recruiting anyone who's experienced a concussion in the WA area over the last 7 days. And then we want to then move forward to do an intervention study. We want to be able to use this information to find the people who are likely to have persisting symptoms and triage them swiftly into a symptom-based treatment approach. There's a number of groups doing this in Pittsburgh in the US, in New Zealand. The clinics are seeing good outcomes, but there's no research-based, evidence-based to actually say, yes, this works. This is the right way to do it. This is what we can persuade our governments that they should spend the money to triage people quickly into treatment and so prevent that 1 in 5 from going on to have poor outcomes. So that is a study that we're currently exploring the options as to how to best do. So this has formed a foundation and has led to a larger scale initiative that I'm involved in, which was called Impact TBI. About this time last year, we had a group of a formative team of people from all around Australia, craft groups that encompassed people from emergency retrieval medicine people, intensive care specialists, psychologists, psychiatrists, basic neuroscience researchers, rehabilitation experts. We all came together and we asked the question, what would change the game for people following a traumatic brain injury of all severity? What would really improve outcomes for patients? And we came up with two aims. The first of which is similar to what we've already talked about today, identifying predictors of poor outcome following traumatic brain injury of all severity. So concussion right through to the severe injuries, children through to adults. And to do that, we would need to do a registry of all traumatic brain injury in Australia, where we actually track all of these factors, put it into a very large scale database where we're not constrained by low numbers, and use machine learning and artificial intelligence approaches to actually find what of all of these plethora of things we're measuring actually will predict outcome. And then secondly, to develop feasible interventions. And to do that, there's no shortage of good ideas to test, but what we need to do is make our clinical trials consistent across all the trauma centres in Australia, make them large scale so that we can overcome the issues of low numbers in trials and site-specific bias. So we were very fortunate to be able to persuade the Federal Minister, Greg Hunt, to call a mission for traumatic brain injury, so $50 million over 10 years. And that mission is now in its formative stages, where we're choosing the members of the expert advisory panel who will choose the funding priorities, and moving forward set in place the research programs that will hopefully change the game for people with traumatic brain injury. And associated with this, we're setting up a public beneficiary institute, a charity that is going to accept leverage funds from state governments and institutions in order to support and enhance the work of the mission and to move forward so that we can really make a difference for people following a traumatic brain injury of all severity. So I'll draw it to a close now, but I would just firstly like to thank in particular Ola Gotts, who's the PhD student, for the data that I presented. Lots of collaborators. We have to work together as a team in this space in order to make a difference. And so I'd like to thank them and also my funding bodies. So thank you very much.